Hello, my name is Britte Lowther. I'm an internal medicine resident at Mountain View Regional Medical Center in Las Cruces, New Mexico. A prolonged case of cyclosporiasis in an immunocompetent host. Introduction. Cyclosporiasis is an intestinal illness caused by the microscopic parasite Cyclosporiasis and acquired by consuming food or water contaminated with the parasite. Reports of cyclosporiasis diarrhea are rare. In a review of cyclosporiasis reported in the United States between 2011 and 2015, there were 2,207 reported cases, which included 10 outbreaks. Symptoms do not always develop, but most commonly include anorexia, nausea, vomiting, watery diarrhea, abdominal cramping, fatigue, and fever. Symptoms may present as a single self-limited episode or a prolonged waxing and waning course lasting weeks to months. The most severe cases have been described in the setting of HIV and are often associated with biliary complications such as acalculous cholecystitis. This case illustrates an immunocompetent host with a prolonged course and possible pancreatitis. Here's the case presentation. A 53-year-old male with past medical history of non-insulin dependent type 2 diabetes mellitus, sleep apnea, hypertension, and tobacco dependence presented to the emergency room with a one-day history of nausea, vomiting, crampy abdominal pain, and diaphoresis. He had recently traveled to Juarez, Mexico, and purchased fresh, washed raspberries from a street vendor. Physical exam was unremarkable except for some mild epigastric discomfort. He was pretty comfortable talking on his cell phone. He really just wanted the doctor's note so he didn't have to go to work the next day with diarrhea. Understandable. A diagnosis of viral gastroenteritis was made and he was discharged. He presented to the ER again on days 8 and 10 from illness onset, having 8 to 10 watery, non-bloody bowel movements per day, however, no vomiting. A diagnosis of acute pancreatitis was suspected at this time, which I'll explain later. His outpatient medications, which included metformin and pioglitazone, were held. Metformin has a side effect of diarrhea, and pioglitazone has a side effect of acute pancreatitis. On day 16, the ova and parasite sample collected on day 8 resulted positive for oocytes resembling cyclospora. This was reported by the Public Health Department on day 20, and the patient was placed on nitazoxanide, 500 milligrams BID, completing a 3-day course. The patient reported improvement of his symptoms within days of starting the treatment. However, he continued to have waxing and waning symptoms until day 50, when all his symptoms resolved. Later that year, he was resumed on his diabetic medications without reoccurrence of symptoms. Now I would like to go over the workup and timeline with the labs. On day 1, when the patient presented, his CMP and his CBC were unremarkable. Liver enzymes were normal. When he came back to the ER on day 8 and 10, his liver enzymes had taken a bump. ALT was 86, almost double from previous, and AST was 65, again almost double from previous. The lipase was 150. That is 3 times the upper limit of normal of our lab at Mountain View. That, along with his epigastric pain, met 2 out of 3 criteria for a diagnosis of acute pancreatitis. I have his actual CT abdomen and pelvis below in figure 1. And you can see that there is no acute pancreatitis seen, just a little hepatomegaly and some diverticulosis. But we could make the diagnosis of acute pancreatitis just based on the epigastric pain and the lipase. An ova and parasite were sent. The stool culture came back negative. On day 16, that's when the ova and parasite, which is the same as a microscopic exam on a wet mount, resulted positive for oocytes resembling cyclospora. The pathologist noted at that time that further testing could be done to confirm diagnosis of the organism. Unfortunately, we did not do this. On day 20, the diagnosis of cyclosporiasis was communicated to the provider and the patient was started on treatment. Further workup on the same day started treatment also revealed slight elevation of ALT and AST, a little bit down from before. Lipase had increased to 161. He was non-reactive for HIV 1 and 2. On day 50, the patient was seen in clinic, and that's when he reported resolution of symptoms. On day 85, and this is, he'd been without symptoms for quite some time. You can see that his liver enzymes had returned to normal, and his lipase was only 49. He was resumed on metformin and pioglitazone at that time without recurrence of diarrhea. Discussion. Cyclospora diarrhea in an immunocompetent host averages 19 to 43 days, and symptoms usually resolve within 2 to 3 days of starting first-line therapy with TMP-SMX. This case illustrates a prolonged course, 50 days. However, significant improvement was noted between days 20 and 25 upon treatment with nitazoxanide, considered second-line therapy for Cyclospora. Cyclospora is often confused with Cryptosporidium, hence the reason this patient received nitazoxanide. That's first line for Cryptosporidium, not Cyclospora. Luckily, the patient did get better with the second line therapy. Result reporting limitations are highlighted in this case. The ova and parasite is going to look quite similar between Cyclospora and Cryptosporidium, as you can see in figure 2 above. In the upper left-hand corner is Cyclospora, and at a lesser magnification in B, you can see Cryptosporidium. In actuality, if these were the same magnification, the Cyclospora is about 8 to 10 microns in diameter, while Cryptosporidium is more like 4 to 8. But the largest Cryptosporidium can be the same as the smallest Cyclospora, so they're easily confused. This is why it's important to order additional staining acid-fast in this case, and to have a pathologist take a look to determine the identity of the organism. It is up to the provider to order this additional test, and that is the main point I would like to make today. Thank you.